Good evening, and welcome to this program here on blackdoctor.org. I am Ellis Dean, the Director of Digital Program and Production at blackdoctor.org, and we are excited. It's that time again to open your eyes. This is our program, our six-part series on diabetic retinopathy. uh, Hosted by, co-hosted by me, but really the man of the hour is Dr. Joe Cody. So welcome, Dr. Cody. We're excited to have you here again with us this evening.
Ellis, always a pleasure. Thanks for having me again.
So before we get into tonight's topic, we're going to talk about that double danger, diabetic retinopathy and glaucoma. So Black folks, we know the seriousness of glaucoma in our community, and we're going to go through some of the statistics a little bit later on and talk about glaucoma and give you some remedies, what it is and what the treatments are. But first, we've got a couple of things we want you to do. Number one, we want you to share where you're watching from. So drop those in the comment section. Let us know where you're watching from all over the country, all over the world. We had some people from Nigeria last night. So shout out to our folks, our brothers over there in Nigeria. Also, number two, if you know somebody that needs this information, somebody that might be diabetic, somebody that might be having some visual issues as a result of their diabetes, tag them, share this program on your page because there's some valuable information that we're going to be giving out. And also, finally, if you have any questions, please do not hesitate to ask them and drop those in the comment section. Let us know what you need to know, and we'll get those questions asked and answered. So there is that. So, Doc, can you believe this? I think this is our fifth program.
That's right. It's the fifth one. Time is flying.
It has been flying by, and it has been fantastic. But again, this series about diabetic retinopathy, and we talked about diabetic retinopathy in many ways, but we really talked about it on the first show. So tonight we're going to do kind of a review of what it is, and so our audience can know. So if you're just joining us, you're going to get this for the first time. If you've been with us the entire five parts that we've done thus far, thank you so much. You're going to get a review, and there's no problem with getting a review because that means the more you hear it, the more you're apt to remember it and do something about it. So first question is, what is diabetic retinopathy?
So that's I always think that's the most important question because I'm always amazed at how many people still just not know what diabetes means or sugar means or sweet means. It's all mean the same things. The medical term is actually, diabetes. And because diabetes is a chronic problem, it causes other problems besides what you see in the body. And it really affects end organs. It affects your kidneys, it affects your heart, it affects your toes, it affects your brain. And what I do, it also affects your eyes. It affects the blood vessels in all those organs and the nerves. And when it comes to diabetic retinopathy, it's when we see abnormal, capillaries start to get damaged, abnormal blood vessels develop, leaking blood vessels that develop diabetic macular edema, which is the leading cause of decrease in vision. And that typically involves the middle of the eye. And when you have abnormal blood vessels, they can bleed sometimes, and people see these floaters. And then you also can get into more advanced stages, tractional detachments, which obviously need surgery. So there's a whole spectrum of diabetic retinopathy. I think the most important thing that your viewers should know is that in the early stages in diabetes, there's not many symptoms. And that's the reason why people don't come in early enough. That's the reason why we recommend that when individuals are first diagnosed, they come in to get evaluated by an eye care professional, whether it's an optometrist, whether it's an ophthalmologist. We want to make sure that their eyes get dilated. We can look in the eyes and see these things just with a simple exam because oftentimes there are no problems. And then later they start to have splotchy vision, blur vision, sometimes distorted vision. And then later on, as the disease progresses, they can have no vision. And all these things can be caught early just by going in for a dilated screening exam upon diagnosis.
So you said there are not a whole lot of symptoms. At what point do you start seeing symptoms? Is it just a blurry vision? Do you feel like that floater? What is that floater? You mentioned that. I was like, I've heard that before, but help us understand what a floater actually is.
So floaters doesn't always have to be diabetes, but most time it is a sign of aging. And oftentimes it's just the gel in the eye, which is the vitreous humor, aging, turning to liquid. And as it pulls off the back of the eye, we can see a floater moving around the eye. And that's a normal aging process. It becomes problematic when you have an increased amount of floaters or increasing flashing lights, because this can also be the first indication of a hole or a tear in the eye, and that can lead to a detached retina. When it comes to diabetes, you know, early on there may be no vision problems, but as the disease progresses, you're more likely to have different types of vision problems, which can be more common. And that's when you get the blurry vision. That's when you get the splotchy vision. That's when you start to see the floaters if the blood vessels bleed. So a floater could be anything that that blocks the light that comes in from the back to the eye to the back, from the front to the back, and your eyes just see a shadow.
Oh wow. Okay.
You can have inflammation, have a floater. You can have blood that can be a floater. You can have just a normal gel movement that can also be a floater.
Okay.
It's a description.
Okay. So, as in any kind of medical condition, there seems to be some stages. All right. So I understand there are stages of diabetic retinopathy. So what are those stages, and what is the point of no return? Which stage do we get to? We have that point of no return. In many cases, like people say, oh, you're at stage 4. That means only thing we can do is just kind of pray for you kind of situation. What is the stage where we're like, okay, that's when it's really getting bad?
Well, the stages of retinopathy, we do have numbers. I think to keep it simple, we'll just call it mild, moderate, or severe. And that's non-proliferative retinopathy. So we break them up into 2 categories: those that have blood vessels and those that don't have blood vessels. When you don't have blood vessels, we just call it non-proliferative diabetic retinopathy. When you do have blood vessels, we just call it proliferative, and those all have the different stages. And as you go down this tandem, then you're more likely to have those leaky blood vessels, which we call diabetic macular edema. Now, that can occur at any level, but as the disease worsens, it's just more common.
Okay.
When I typically see people that when they have the no point of return, oftentimes they have what's called a tractional retinal detachment. It's detaching the more important parts of the eye, which is the center part of the macula, and that often needs surgery. I'm not going to say that we don't rehab some of these eyes. I have many people that have horrible looking eyes, and we're able to salvage those eyes so they can drive again. But unfortunately, that's not the majority of people. And I think what your audience needs to know is that if we catch things early, if we diagnose them at the right stage and institute therapy early enough, there is no reason why anyone needs to lose any vision from diabetes, because we have medications that can decrease the level of the disease before you lose vision.
Absolutely. So it sounds like as soon as somebody gets I know somebody should start seeing a eye specialist as soon as they get diagnosed with diabetes. Should they start, if they realize that they're in that pre-diabetic range, should they start seeing an eye specialist just in case, just to start that process of monitoring their vision?
Well, Ellis, I think it's important for all of us to have good health. Regardless. Glaucoma is one of those things we'll talk about. Later. So you need to get screened for glaucoma. You need to get screened for cataracts. When you hit about the age, the late 40s, early 50s, we're all going to lose our ability to start reading up close. So you need some reading glasses. So you just want to make sure it's just not you getting more presbyopic or the inability to read up close, but you want to make sure there's nothing else going on in the eye. So just having general health is important. And if you have a family member that has lost their vision from diabetes and you're pre-diabetic, there's no reason why you shouldn't go in and just get evaluated.
Okay. All right. So what are some of the treatments that are for folks that are suffering from diabetic retinopathy?
So it really depends on the level and what's going on in the eye. So the one thing that's really changed our landscape, and I really want your audience to understand that this is really, really important, because it does take some time for us to build up that equity, that communication with the patients, because they need to come in sometimes on a more frequent basis to get injections in their eye. And I know that's a hard thought for us to understand, that we need a shot in our eye, but that shot in the eye can stabilize your retinopathy 95% of the time and can improve it up to 40%. Now, we still do lasers for the eyes, and there's different types of lasers. And then again, the more advanced forms, we still do what's called a vitrectomy, where we actually go inside the eye to remove any of the scar tissue and remove blood. And these are things that injections and lasers just can't do alone.
So just as a personal note, is that injection, do do they get like anesthesia before you do that injection? Because I don't know how many people can sit still with a needle going towards their eye.
I know it sounds crazy. We've been doing this now for over, 16 years. It has really changed the landscape. We do this right in the office. People come in on a monthly basis. Most time they're very comfortable. We do a little topical anesthetic. We clean the eye off to make sure that there's no infections. And we have really streamlined how individuals receive these injections. Obviously, there are people that will be discomfort. Most time it's a dryness or grittiness. And I always tell people just use those artificial tears as much as they need to after that injection to just get them over the barrier. But I think the most important thing is that 5, 10 years later, they're still seeing versus not coming in and not being adherent to their appointments. Because ultimately you're going to hurt yourself by not getting the therapy that your doctor recommends.
So I think I'm going to say it plain because you're being very nice as a physician. So 5 to 10 minutes of discomfort is worth saving your vision, right? And having improved vision, right? Because if you want to avoid having that, and I'm not trying to discount anybody who has anxiety. If you've got severe kind of needle anxiety, then there's probably some other methodology for that. But I'm just talking about somebody that says, it's uncomfortable. Be uncomfortable for 5 minutes to maintain and preserve your vision. It's worth it.
And Alice, and if you have any patients that are if you have any in your audience members are if they getting injections, you can talk to your doctor. Let them know exactly what your discomfort is. Let them know why you missed that appointment and what your apprehensions are. Maybe they have a different way to numb you, a different way to add in the betadine. The betadine is really what burns the most. Some people don't like the speculum that goes in the eyes. So sometimes I'll use my fingers to open up the eyes versus using the speculum. Sometimes I'll use a little betadine on a Q-tip versus pouring in the eye, which obviously gets all over the eye. And so there's different ways we can do some things. We can put a little anesthetic in the conjunctiva as a deeper numbing. So if the doctor know that you're having a really discomfort, I think the most important thing is that they want you to keep coming back. And there are ways for us to make you more comfortable.
All right, you guys, you heard it here first. So get it done. I'm still trying to really wrap my mind around it, but because I'm not super needle phobic. I'm kind of like in that middle range where I'll get shots and blood drawn. I don't have any problem with that. I don't jump out of the chair. You don't have to strap me down or anything like that. But I can't look at it, right? So I just kind of just turn my head and let them do it. But when it's in the eye, it's kind of hard not to look at it because it's coming right at your eye. So that would be, I would say personally, that would be a challenge for me. Okay, so all right, I'm going to ask the most obvious question in the room, but we still have to kind of reiterate this point. How can diabetic retinopathy be prevented?
I think the most important thing is getting in to have that first exam. In this country, our screening policies, I think, are actually pretty good. The problem is that 50% of the individuals don't come in for their screening exams. And even with the optometrists, if they see someone with retinopathy and say, hey, you need to go see a retina specialist, we still lose 30% of those individuals, probably because they're not having any problems seeing. It's amazing where we don't see a physician if we don't have any problems. But if you have pain, if you have an abrasion, you'll come in. But someone telling you that you're going blind from diabetes, you won't come in because you're still seeing. That really, really amazes me. But it tells me that if we're uncomfortable, we're going to call for a doctor. But I think the most important thing, again, is once you get in and once you're plugged in, then you're in the know. And it's our job to educate you what's going on with your eyes, hopefully show you some photographs of what your eyes look like and what our goals are for you. And if you stick on this goal here, I can probably give you a short-term plan and a long-term plan once we start therapy, if therapy is what you need. Now, if you don't have any retinopathy, that's great. We'll do a lot of education, and we'll tell you the reason why we need to have you to come in annually just to make sure it doesn't happen. Because in diabetes, sometimes the progression can be fairly fast. So the most important thing for me is the baseline of when someone comes in to see me. So if someone comes in with severe nonproliferative diabetic retinopathy, I know that person has a risk of 50% of having severe vision loss within the next 3 to 5 years. And if I start therapy when they have not lost any vision, I can reduce that level of disease to more mild or moderate levels of disease. And now their risk is 15 to 25% over that 5-year period. So I've reduced the ability of them having any loss of vision. But that really requires them going in and having that eye exam and having that discussion with their doctors about their eye health and what they can do to maintain their vision.
Yes, sir. Okay, so what is you said you dropped a $10 word on me there, Doc. Non-proliferative. What is that?
Well, non-proliferative just means there's no diabetes. I mean, there's no abnormal blood vessels. So we break them up into uh, blood vessels and non-blood vessels, or proliferative or non-proliferative. I think also things for your viewers, and this is really good also for the pre-diabetics. Is part of it is it's not just your blood sugar that's important, or your hemoglobin A1C, which is the average sugar over that 3 months, but controlling your blood pressure, controlling your cholesterol, your diet, your exercise. Obesity is so much higher in the African American community because we have sedentary lifestyle. We love that southern cooking. It's hard to break away from the potatoes and from the rice,
Yeah,
and those things are not good for us, at least over abundance. The salt is really important because we know that African Americans handle salt differently.
right.
That has to do with how your blood pressure goes. Smoking, we all know smoking is bad for our health, but yet we still do it. So all these things, these are the other things that you can do to maximize, to improve your health. And it's not just for your eyes, but this is also for your heart. It's for your circulation. It's also for your mentation. All these things are, these fatty foods that we eat, they're so full of not just fatty foods, but free radical formations, which cause inflammation in our bodies. And all these things, just by changing to a green leafier diet, all these things will help all those inflammatory problems that we normally have in our body.
Absolutely, absolutely. You're right. Obesity is kind of like that center spoke of the wheel, and all of these other conditions kind of spring out from that. Just obesity. There's a couple of comments that are questioning and then supportive of the eye injection. So Sean is saying, he said, I was afraid to do injections in the eye. After the first time, it's not that bad. They numb the eye with drops and inject the outer corner of the eye. I receive Avastin injections, and it has helped. So you've got some support there, Doc, in terms of the eye injections.
And Sean is absolutely right. And unfortunately, Sean, I think you probably agree that the betadine solution that we have is probably the worst because it burns a little bit. We do anesthetize the eye, but that betadine is really important because whenever you put a needle any place in any orifice or any place else, once you puncture the skin, there's always a small risk of infection.
Yeah.
The risk of infection with injection is extremely small, about 0.3%. And that betadine is critical so individuals will not get an infection.
And then Mary's saying, how many patients receive these injections? I guess Sean answered the second part of her question. She's asking, are they really pretty comfortable? But the first part is about, on average, how many patients are receiving these type of injections in terms of like a percentage of patients?
Well, if you look at diseases, the most common sight-threatening disease we have in our country is really macular degeneration and diabetes, and both of these things are increasing. With diabetes, is just increasing at a huge rate. The World Health Organization has labeled diabetes as the first non-infectious pandemic. So this is a problem not just in the United States, but actually worldwide. About 30% of the individuals that have diabetes will develop retinopathy, and half those people will develop a diabetic macular edema. And we know that the prevalence of diabetes is much more common in African Americans, the Latinos, the Asian populations. And so the number of injections are much higher in those individuals because the burden is actually higher. So when you look at all comers, we, on our average, we do about 70,000 injections in my clinic alone. And that's just here in Northeast Ohio. So that's just a small area, but it tells you how effective it is. And I think Sean will tell you that, there's multiple injections involved in it. It's not just a one and done. And that's what people often believe in. And that's where I was saying you have to buy that equity and hope the doctor can help you understand on why those repeated injections are important. Because we know that after you get through that first year, the number of injections typically goes down, but you have to stick it out, get stable first. And then once you get stable, then your physician or your doctor is able to extend out your appointments.
Okay. So you're saying the first year is monthly, and then after that, it can extend out.
Not quite monthly, but I think it's a heavier lift, and it all depends on what level of the disease. I think that this is where social determinants of health is really important. So we have strong data that shows that Medicaid patients come in at a worse level than Medicare and private insurances. We
Right.
know that Black and brown people will come in with more advanced disease. So the more advanced the disease is, the more swelling you have in the eye, the worse the retinopathy. Your number of injections are oftentimes much greater to get that eye stable. There are some people that may only need 3 injections and their retinopathy is stable, and that we can extend them, pretty early. And I have some people that need injections every single month for a year. So it's really dependent on the level of the disease, and that's the reason why I stress, if you get in early, although you have a problem, the burden of therapy may not still be very great.
Okay, wow. So if you're just joining us, we are talking to Dr. Joe Coney as part of our series called Open Your Eyes. And tonight's conversation is called Double Danger. We're talking about diabetic retinopathy, which is the underlying kind of theme of all of this 6-part series that we're doing. And we're also going to be talking about glaucoma. And glaucoma is that second part of this double danger theme of tonight's program. So ask your questions. So we're going to shift a little bit and talk a little bit about glaucoma. And there is a relationship between diabetic retinopathy and glaucoma. So folks, stick around, hang tight, because we're going to talk about that relationship. So just in a general overview, what is glaucoma?
So glaucoma is really an optic neuropathy. It's a chronic problem where the optic nerve gets damaged over time. And in glaucoma, most times it's related to elevated intraocular pressure, although it doesn't always have to be pressure related. Oftentimes, the pressure is higher in the eye, and the increased pressure in the eye would damage the optic nerve and the tissues around the nerve, where slowly the vision can decrease over time. Now, when we look at the glaucoma, it's the same way that we look at diabetes. We put them in 2 different buckets. In glaucoma, you have what's called primary open-angle glaucoma, and then there's a closed-angle glaucoma, and then there's a lot of secondary glaucoma. So let me just tell you the difference of these two, because I think this is the most common thing. The most common type of glaucoma is primary open-angle glaucoma, and typically this is when the vision loss is extremely slow, and people don't come in early enough because they don't have any symptoms again. Okay, and glaucoma affects your peripheral vision. So most of us don't use our peripheral vision much because we tend to turn our heads. But as the glaucoma increases, then you start noticing that your depth perception may not be too good. You don't see the person sitting, next to you. And so this is when people come in when the disease have already progressed. And in closed angle glaucoma, these individuals will have a rapid increase in pressure. So the eye is painful, the eye is red, the eye is teary, they have glare, and this is a medical emergency. This is where people come in and just the angles, narrow angle glaucoma, the angles are just very narrow, they close up, and just a quick laser in the office can just relieve the pain and relieve the pressure. And I think that's really, really important because people may have headaches, don't know why they're having headaches, don't know why they're having pain, and they may think it's just a routine, just migraine, where in reality, it actually may be a narrow angle glaucoma. And there are certain medications that can exacerbate this, like the anticholinergics that people use for like bladder problems, even some of the sulfonamides, which is some of the antibiotics. So if you're on certain drugs and you start getting eye pain and your eyes start getting teary and blurred, you may just want to go in and see an ophthalmologist just to make sure you're not having problems. And oftentimes, this is what they mean by if you have an eye condition, there may be a side effect. This is oftentimes what they mean when you have glaucoma on those little packet inserts that comes with your medications that you get from the pharmacy.
So I was doing some research earlier today because I'm not quite as smart as you, so I had to look up. I had to go to Dr. Google, and I found some interesting statistics for our audience regarding glaucoma. So they said glaucoma occurs about 5 times more often in African Americans, They said blindness in African Americans is about 6 times more common in African Americans. Also, it occurs earlier, on average, about 10 years earlier in African Americans, and this is in comparison to white Americans. So, because I know there's a different rate for Hispanic or Latinx community, but this is as compared to white Americans. And also, research has shown that Black Americans are genetically more at risk. And so this is where people start getting a little bit like, oh, what you say? We're genetically predisposed. And what they're saying is that people of African descent, there was an African descent and glaucoma evaluation study group that found that African Americans have thinner corneas than those of European descent. And the corneas are a known risk factor for glaucoma. It's also found that African Americans have a larger optic nerve. And this may be important as people with larger optic nerves are more often misdiagnosed with glaucoma. And then finally, it found that African Americans with higher eye pressure tend to get worse more quickly than their white counterparts. And so that vision diminishing goes a lot more quickly. So did Dr. Google get it right or were they wrong?
Fellas, all those things are correct. And this is the reason why I stress you need to go in and get a full evaluation. That full evaluation, when people come in for glaucoma, let's just talk about what that looks like. Oftentimes, is definitely checking your pressure. And that's when we just put something very close to your eye and we can actually measure the millimeters of mercury of what your pressure is. Normal pressure is between 10 and 21. Okay. You also want to do a good detailed exam of the front part of the eye. Just make sure that the angles are not narrow. Make sure there's no scar tissue. Even inflammation. If you had a herpetic eye disease, for example, you can get some damage in the front of the eye or any kind of trauma. If you get blunt trauma to the eye with anything, those will increase your risk for having glaucoma over time. And then you want to just make sure that the eye is healthy. But also, I think you hit something on the head. Checking the cornea pachymetry. So cornea pachymetry is looking at how thick someone's cornea is. This is really common when they do refractive surgery. They want to make sure that you have a thick enough cornea for them to do an ablation zone when they're reshaping your cornea for refractive surgery. African Americans tend to have a thinner cornea, which means that you don't need as much. You need more pressure in order to when they check it to actually get an actual pressure, more force to actually get extra pressure. So if your corneas are thinner, you get a falsely low pressure. So there are people that's called low tension glaucoma, where they come in, the pressure may be 17, 18, which is normal, but if their corneal thickness is thinner, which is normally less than 500, microns, let's say it's 450, your pressure really could be 24, 25. So people come in every year and their eyes getting worse, or they come in one time for a screening appointment because they had a normal pressure and didn't have this other stuff done. They missed the opportunity to diagnose someone with a thin cornea that may put them at a higher risk for glaucoma because their pressure was falsely low. So this happened to my mom. My mom has really thin corneas and she was getting worse glaucoma every single year. And then so I actually talked to the doctor and I said, did you check her corneal thickness? He's like, oh, we didn't do that. Well, he checked her cornea thicknesses and it was 100 microns thinner. She was extremely thin. So her pressures were actually in the 30s when he was actually measuring someplace in the teens.
Oh,
and so
wow.
she was never started on eye drops.
Okay.
Large nerves put you at risk. So even people with myopia or nearsightedness, those are long eyes and they typically have larger optic nerves. Those people are also at risk. I think your biggest risk factor besides race is really your family history.
Okay.
If you have someone in your family, your mom, your dad, your brother or sister, your rate of developing glaucoma is much higher than someone that does not have that risk factor. So if you're Black and you have a risk factor and you have big nerves and slightly elevated pressure, maybe even high normal, you are a glaucoma suspect until proven otherwise, and you need to go in, have repeated exams until something changes. So the last part of this is that we now can do imaging of the optic nerve and see damage before someone loses vision. Okay. And we also can do something called visual field testing. And that's how we examine the peripheral vision to see if there's any nerve fiber layers damage that's really caused problems. And we can see those patterns over time. So serial exams will give us a lot of data points to see if you are progressing or not. And once the doctor sees you progressing, that's typically when they want to, that's when you switch from a glaucoma suspect to actually being guilty as having glaucoma. And that's when they start your medications.
Absolutely. Well, okay. So let's talk about treatment. So what are the treatments for glaucoma? I know there are some drops. There's some drops that can be placed in the eye to kind of relieve some of that pressure. But what are some other things? And then also, I want to make sure that we point out that if you go see an ophthalmologist, when you go for your exam, and he does a test of thickness, and you got a family history, that thickness of the cornea, just ask. You say, hey, doc, I was watching this program on Black Doctor, and they talked about Black people having thinner corneas. Could you check the thickness of my cornea to make sure that the numbers, that the readings you're getting on my pressure is right? One, you're going to shock the hell out of them by asking that question. That's an informed question. And two, you're going to advocate for yourself in that situation, and that could help him recalibrate some of those numbers so you don't suffer the same fate that Dr. Coney's mom did, where they're getting kind of a false negative.
And this is what I like about your series, that we all start teaching people how to become advocate for themselves.
Yes,
help them to have the conversations with their doctors in order to get more information. Because if we don't know that information, it's hard for us to understand what the doctor should be doing or not doing. Right. And so we want to make sure that health equity is done correctly when we're seeing our physicians, make sure that we're getting the exact same care, make sure that all the testing are done the exact same way. And I think the only way to do this is to make sure that everyone is streamlined and doing the exact same thing. So part of your evaluation should be checking your corneal thickness.
Absolutely. Okay, so let's talk about some treatments for glaucoma outside of the drops.
So I'm gonna make it real simple. The way we look at glaucoma is like a faucet. And so you can cut the faucet up real high, where so much water is coming to the faucet, it just bags up. Okay. Mm-hmm. Or there's something in the faucet where is inhibiting the water from getting down the drain. So like a plate blocking up the drain, or something in the drain itself. Okay. So that's the way I look at glaucoma. So we have medications that can work on decreasing the faucet, decreasing the amount of fluid your eye makes, so it has a faster time to drain out. We have a way to open up the drain. So we have medication to open up the drain. And then if the drain is actually blocked, we have surgical ways that we have stents that can go in the eye, around the eye. There's also little blebs that we can make in the eye. That's just a conduit from the front to the outside, so to speak, that can lower the pressure. There's valves we can also put in the eye as well. So there's all these different procedures. So when you're talking to your doctor, and let's say you're on a couple of medications and it's getting hard and burdened to keep putting those drops in, and you can have that discussion with the doctor. Am I a candidate for something else? When do you think I need surgery? There's also lasers that we can do in the draining system to open up those things a little bit as well. And everyone has a little nuances on who's better for what. And so it's really complicated to have that discussion on here, because glaucoma specialists, that's a whole hour discussion just for them, and they're experts. I think it's important for you to know that there are multiple agents. The one I really want to mention, it doesn't give you a huge amount of pressure reduction, but there's also procedures that if you're going in for a cataract surgery, there is a little implant. It's called a MIGS procedure, where they can do at the time of your cataract surgery, they can do a combined cataract glaucoma surgery to give you extra little points of reduction in your pressure. But it's only good at the time of cataract surgery. So you want to have that discussion early on. So if you have glaucoma and you're taking eye drops, doc, am I candidate for any other procedure to lower my pressure at the time you take my cataract out? Have that discussion, ask an open-ended question, and let your doctor have that discussion with you and talk about the pros and cons to see if you're the best candidate for one of those procedures.
And remember, we learned on one of our earlier programs, everybody's going to get some cataracts, right? So it's just like the rings on a tree. You're going to get cataracts as you age, so you can't avoid the cataracts. Some people get them worse, but you're going to get some cataracts, and so really, that's the time to have that conversation with Dr. Coney, saying, okay, hey, if I'm going to get the surgical cataract while you're in there, maybe we could relieve some of that pressure if we're kind of trending down that path towards glaucoma.
I just want to, you kind of mentioned it, but I just want to, reiterate it that if you're about 40 years old and you have a family history, you want to go in and get screened.
Okay.
And I think that's the most important thing. Okay. So screening is not just important for diabetes, but it's also important to make sure that you don't have glaucoma.
Absolutely. All right. So we know this series is about diabetic retinopathy. So I'm going to ask the $50 million question. Is there a relationship between diabetic retinopathy and glaucoma?
Man, most definitely. Most definitely. For one, just being Black, we are at risk for everything. So it's diabetes is the leading cause of blindness in the working age population, and glaucoma is the leading blindness in African Americans. So there is a double whammy. They're not two of the same disease, so you can clearly have glaucoma, you can clearly have diabetes. So you can have both, just because it's because your mom had a diabetes and your dad had glaucoma, you may have inherited both of those genes. So these are things that has to do with, you can have multiple things. But I think the big thing is really circulation of the eye. Low and even having high blood pressure can put you at risk for glaucoma. So, or worsening glaucoma, because it actually, there's been a direct correlation to lowering your perfusion pressure, particularly when you go to sleep at night or lying flat. You don't have as much perfusion to the eye. So if you on certain antihypertensives, you can worsen the glaucoma in your eye.
Oh, wow.
In diabetes, your circulation is also reduced. So you can lower the perfusion pressure to your eye, because diabetes is a risk factor for atherosclerosis. High blood pressure is a risk factor for atherosclerosis. So that's the reason why diabetes, blood pressure, obesity, smoking, all these things are a risk for worsening glaucoma. Antioxidants is a worsening, well, if you have all these, free radicals, I'll call them. Antioxidants is the treatment for it. If you have these free radicals, which oftentimes come from the way we eat, these are also risk factors for glaucoma. Obviously, the main ones is race, age, and family history. Those are the biggies. High pressure. But if you have other comorbid problems, you are at risk. And then if you are at risk and you develop both, because some affect your central vision and some affect your peripheral vision, you can have really detrimental problems with your quality of life.
So I'm going to take a point of personal privilege here and say, okay, guys, so we're talking about being your own best advocate, right? So we know, hey, look, if you've got a family history of diabetes, you've got to monitor your blood sugar. If you've got a family history of glaucoma, you've got to kind of monitor that. But also, when you go in to see the ophthalmologist for your annual eye exam, fill out that paperwork. Give as much information. If you don't know that information, if you don't know somebody had glaucoma, you might know somebody that was diabetic, because diabetic is more pronounced. They've got the shots, they've got the PET, they're checking their blood sugar. If you don't know, that's a quick phone call, right? Before you go to the doctor, call that. There's always somebody in everybody's family that knows what everybody got, right? Whether it's Big Mama, for me on my father's side is my cousin. He knows where everybody is, where they live, and what they doing right now, and what they had in their life. And I got somebody on my mother's side for that same situation. Just a quick phone call so you can accurately fill out that form. So now you and your doctor can have a more serious conversation, and the more information, the better and more kind of targeted that treatment can be, because he can know, okay, there's a higher percentage of this because that person has a family history of glaucoma. But if you don't fill that out, or if you don't know, you just don't check that box, he may not be looking for that. He or she, sorry, I don't want to make that gender specific. He or she may not be looking for that. And then that could delay the diagnosis and could cause more vision loss or more problems by having that diagnosis delayed. So just really, as part of that advocacy for yourself and being an advocate for yourself, make sure you have an accurate family history of, at least it's just your parents, siblings, maybe grandparents. You don't have to go too deep. If you know what your aunt and uncle had, you can bring that into the situation. But really, parents, grandparents, and siblings will be adequate. Is that a fair assessment, Doc?
I agree. And just the more you can communicate with your doctor about your past ocular history, your past medical history, we're able to put together a roadmap and look at what your risk factors are. and know what to follow you for. Because sometimes you come in for one problem, and we may find 3 or 4 issues that we have to talk about. We need to prioritize, what's important at that particular time, and come back to something else later, which may not be as important. You may be bleeding from your eye from diabetes, and I'm not really getting to your glaucoma yet because you got a sight-threatening problems from your diabetes. But at some point, we got to get back and talk about your optic nerves as well. So that we have to prioritize sometimes based on what's going on at that particular time. And it could just be a cataract. Your cataract may be so bad where we can't see your optic nerve. I mean, so where we can't see your optic nerve, or we can't see your diabetes.
Wow.
And so it's not until we take the cataract out that we see that, hey, you know what? You have advanced glaucoma. You have really bad diabetes. You had a stroke in the eye. And so all these things can lead to vision loss. And so that's the reason why it's really important to go in for us to let you know what's going on with the eye, and then try to put a treatment plan together. It may be something very simple, or maybe a little bit more of a complex fix.
And understanding it's all about ratio. What's important? So being a little time lost from work is much better than vision loss, right? So we got to kind of put, what's more important, your vision, or just that those couple extra hours at work. And I understand, look, I understand people have to work. So I'm not really, telling anybody not to go to work, but there's a trade-off. If you're starting to experience some difficulties, and that is not going to go away on its own. You've got to get it treated. You've got to get seen in order to have that. So we got a comment from one of our YouTube watchers, and from Vivian. She's saying she has sharp pain or pressure in her eyes. This started after her heart attack a year ago. Plus, she's on blood thinners, and she has type 2 diabetes. So I'm hoping as a result of that, thank you for sharing, Vivian, but I'm hoping that you are seeing an ophthalmologist on a regular basis, and you're making sure that they're monitoring any potential neuropathy, retinopathy that you might be having. So we've heard, on the streets, that there are some natural remedies for glaucoma. Is there any research that supports that, or is that just kind of an urban myth that you can use cannabis as a way to alleviate some glaucoma type symptoms?
So Ellis, let's just set this straight, because this is really an important issue. It is not just important just for our people, but for everyone. I think glaucoma people are burdened with this question. They've been surveyed before. There's a lot of people on a weekly basis, probably as high as 40%. There's somebody on a given day is asking about this question for a lot of reasons. It's not just for glaucoma. I get the questions for diabetes, for macular degeneration, for my cataracts. Okay, so people sometimes they just want a reason just to have cannabis, and some people are really looking for legitimate reasons to stop their eye drops, or try to or not to have surgery. So cannabis can lower eye pressure. The problem with cannabis is that it's a very short metabolite. It doesn't last very long. That's the reason why we don't have a lot of symptoms or withdrawal symptoms when you stop cannabis like you do from other drugs, because it's very short. Okay, because it's very short, and when I say short, it can lower the pressure for about 3 to 4 hours. Okay. The problem with glaucoma is that glaucoma is a chronic problem where you need 24 hours of suppression. So you have to really take cannabis all around the clock, every 3 to 4 hours, just to get the benefit. So the problem is that the other part of that is not healthy. Right. The change in your mentation, the change in your function, what it does to your lungs, what it does to your blood pressure, what it does to your heart. So the benefits doesn't outweigh what it can actually do. So there's actually no treatment for glaucoma, but it can reduce your pressure. And I think that's the reason why the conversation, and this is done from early studies back in the 70s, and it was done from one of our NMA members who unfortunately, died several years ago. And he had the first lab that looked at this. So I actually had time when he was in Cleveland before he passed, we actually had about 3-hour conversation over a nice steak dinner, having some of these discussions way before it was discussed as a medical therapy. But he was one of the first ones to actually talk about it. But every society, the American Academy of Ophthalmology, the Society for Glaucoma Specialists, no one has recommended cannabis for treatment of glaucoma. Now there are some states where glaucoma is one of the issues where they can get a medical approval. And this is not scientific, but it's on there. So I can't tell you what every state does. Here in Ohio, actually, glaucoma is one of those things that you can have medical marijuana for. But I'll tell you now, it actually can worsen the disease. And here's the reason why. And particularly CBD can worsen the disease. So CBD, which is the non-active ingredient, that actually has been shown to decrease perfusion pressure to the optic nerve. It lowers the pressure. So therefore, you can have progression in the disease itself, in the nerve, where the nerve gets bigger because it's not getting enough oxygen, not getting enough blood supply. So it can actually worsen the disease. And so I don't think we talk about that part enough. If you want to do something herbals, I think you look at lifestyle changes. You know, oftentimes we talk about lifestyle changes when it comes to macular degeneration, but green leafy vegetables are really good for antioxidants. And antioxidants is one of the things that affects the optic nerves. We talk about kale, broccoli, spinach. All those things are really, really good for the eyes. It can significantly decrease the risk of these things progression. Nuts are actually really good for the eyes. Almonds, hazelnuts, pistachios. Those things have one of the highest levels of lutein and zeaxanthin, which is really, really good for the eyes. Fish, we talk about the oily fish, the ones with the high omega-3s, the salmon, the tuna, the herrings, halibut. All these things are really rich in fatty omega-3s, and these are also good for the heart. So, you may get some good effects on the eye, but you're going to get other good effects, other things. And there are some fun things out there too. Dark chocolates, is really good for the eye. It has antioxidants. It's called flavonoids. Those are in chocolates, and so it increases circulation. It increases blood. I'm sure the white chocolates are good too, but the dark chocolates is where it's at. The same thing with wine. The red wine versus the white wine. Red wine is also good for the exact same reason. Bananas. And I was on your show about a month ago, and we were talking about health, and she was telling me that for her diabetics, you got to have one banana got to last you 3 days. And I remember every time I have a banana, but banana is very good, and it's not just good for potassium, but it's also good with magnesium. And we know magnesium, particularly during this COVID time, that magnesium is good for your immune system. It's good for those antioxidants. So these are things that's important. On the flip side, you also have to be cautious about what you eat. And these are the foods that are high in fats, because it's those high fatty foods that have all the that have all the free radicals that increases atherosclerosis in your arteries. It increases the damage from the diabetes in your eyes. Also has the same kind of effect for glaucoma. So it's not just what you eat, all the good things, but you have to remember the things that are not healthy for your eyes as well.
And you have to pair that with some exercise as well. So that we eat well and pair that with some exercise. Vivian asked a question. This is the question that always comes up. What about carrots?
Vivian, my mother gave me a lot of bad information, and carrots one of them. Carrots are good for you, so you should definitely eat them. We may not be getting the benefits that we want in the eyes that we think we are, but carrots is a very good food. So we should definitely eat our carrots, but not for the reason that you're going to see better. Rabbits have great vision, so we think carrots, do really good for our vision, but it's not always true.
That might just be genetics, or the rabbits and their hearing and their eyesight. So green leafy vegetables, the fatty omega-3 fatty acids, fish. So that's your salmon, halibuts, tuna, and whatnot. Eat those. We talked about bananas. Nuts are good. So there's some foods that are part of our diet. I'm talking about Black folks that are part of our diet and increase those foods, right? Eliminate some of those fatty foods. Eliminate the chips, the trans fat. my feelings got hurt the other day. Somebody told me I had to stop eating that microwave popcorn because it's very high in trans fat. So and I got to get my son off it. And I'm a popcorn fiend, so I got to figure out how to get my popcorn fixed without using that microwave popcorn, because those trans fats are not good for you. Because all that the test that you always say that it makes it easier is, when you fry that bacon grease, and you just leave that bacon grease in a pan. You fry your bacon, you leave the bacon grease in a pan. If it gets hard, that's not good, because that's what happens in your arteries, right? When you eat that's what happens. It hardens up. Oils like olive oil, that's natural olive oil. You can leave it in the pan; it's not going to harden up. That's better for you in terms of those natural oils. So, like, I know we like to put some bacon grease in the pot. I get it. I'm with you. I'm old school too. I had the coffee mug, and you pour the bacon grease in it. I learned from a grandmother, and you use that for flavoring later on. But it's not good for you, folks. So there's other ways to flavor your food. There's some great herbs out there that'll get you the flavor that you want without having the harmful effects of fats and salts and sugars and all the stuff that we tend to crave in our diet. So I've had to work hard myself too, because it's addictive. Sugar is addictive. Fats are very addictive, and they're ready and easy to find, and they're inexpensive, right? So when you go to grocery store, what's the cheapest meat? The cheapest meat has the most higher fat content, right? The ground beef, so those things like that, they have higher fat content. The more expensive meat are leaner. So you have to work within your budget, but there's ways to, if you shift that mindset to half my plate should be vegetables, a quarter should be maybe some rice or potatoes, and a quarter should be meat. If we fill that plate up with those green leafy vegetables, we'll get what we need, and you can still get that flavor from meat. I know I'm not vegan yet.
So. And I do want your audience to know that none of these things can actually stop these. These are not things that, you won't get glaucoma, you won't get diabetes. This just helps you to decrease some of the progression. Aging is going to happen. Things are going to happen, but we want to age gracefully. Yes. we want to age, with our own dignity and being able to take care of ourselves as we transition. And seeing our loved ones at the end of our lives, I think, is important. Not being in pain in our lives is important. So the things you put in now, you would get them back on the back end. It's kind of like a savings account, and all those things are really, really hard. But because we're young, our bodies can take eating a couple of Big Macs and fries and a shake and an apple. I'm telling myself, because that's what I got when I was a kid. That's what I got every single time I went to McDonald's. But I can't do that stuff now. I'm 50 years old, and I'm much more aware of things. I still have a long way to go, for sure. But at least I'm aware of the things that I eat, and also the things that you drink. Because drinking excessively can also contribute to some of these same issues.
Yep. So a couple more questions as we're getting close to the end of our time. First thing is, let's talk about what's next, right? Because there's some two hot words in kind of the healthcare space, and that's clinical trials. Are there some clinical trials that potentially could help with diabetic retinopathy and or glaucoma?
So I'll speak to diabetic retinopathy since I'm a retina specialist, and that's what I do. Right. We now have one of the first industry-sponsored clinical trials looking to treat underserved individuals with an approved drug. So let me back up and let me put this in context. So when we do clinical trials, when medicines come to are available for everyone, once they're FDA approved, there's a clinical trial. There's normally 3 phases to a trial: phase 1, 2, and 3. Phase 3 is when it gets approved by the FDA. And there's a set number of people that are enrolled in a clinical trial that we learn from how a drug works, how safe is a drug, and if it addresses an unmet need. The majority of people in those clinical trials, regardless of disease states, are Caucasian people. 90% of the databases that we have currently for our clinical trials are from European ancestry. So what does that mean for us? So let's just take it one step further. Let's take something more common to all of us: prostate cancer. Prostate cancer has a 40% mortality in African American men, but yet less than 10% individuals, Black men, are in clinical trials. Mortality rate for breast cancer is about 40% higher in African American women, but yet they are less than 10% in the clinical trials. It's the same thing about diabetes when it comes to retinopathy. We don't have enough Blacks in our trials to see if the efficacy and the safety is the same for each participant in the trial. Now, once those drugs come to market, everyone has access to those drugs. What we don't know is that is there a differential response based on gender, ethnicity, or race? However we normally classify ourselves by our ethnicity.
Right.
Race is really kind of where we migrated from, which is a little bit harder for us to do, because we do know that genetic makeup, people can have different responses, and we learned so much of that in breast cancer, where if you don't have a certain gene in breast cancer, the medication doesn't work very well. And so we are now looking at a clinical trial for Blacks, Hispanics, Asians, people from Hawaiian descent, because these groups of people are often not involved in the trials. And we're looking also into the social determinants of health, how we can improve that, how we can improve the relationship with those communities. And we try to address all the barriers that has led to a poor recruitment.
Yeah.
And so we're hoping to get a lot of great information. That trial is ongoing. It's a nationwide trial. It's called Elevate 'em. And it's with a drug that was already recently approved for diabetic macular edema. So we don't have to worry about some of the safety issues. It's already approved. The great thing is that the medication will be given for free. You can get, and they're taking care of all of this. If you have a hard time getting to the clinic, we'll provide you a vehicle that'll pick you up at your door, take you to your appointment, and take you back home for no cost whatsoever. We also would take care of the other eye. So this is what the trials are doing, and we're so happy that industry is listening to the unmet needs of the community, listen to their constituents, which is their physicians, to let them know what we need to better serve people, to make sure that everyone is getting a fair treatment, so we can address disparities in this country.
Could not have said it any better. It's very important, because involvement improves outcomes, is what Dr. Coney is talking about. We have to get involved in these clinical trials from the beginning, because they're going to set the norm of that medication based on who's in the trial. And so if it's only white men that are in the trial, they're going to say, okay, this is the dosage amount for that particular medication, and that may not match with our ethnicity. And so we'll take that medicine based on a white male's dosage, and we're not getting the same results. And then what can happen is we can stop taking that medication. We can stop going to that doctor. Oh, that doctor don't know, we talk about that medicine is not working. It was not working because it wasn't normed for Black and brown people. And so participating in that clinical trials allows the researchers to be able to norm that medication more so what Black people, this amount, we need this amount. So really it just helps them get more information to make that medication better for all people, instead of the groups that participate in that trial. So, and some of the trials aren't even about medication. Some of the trials are just about treatment methodology. When do you take it? Should I take it at night versus in the morning? Some of them are just really, there's a bunch of clinical trials, and I think it's really, really important. So we're going to have on blackdoctor.org, we'll be launching a clinical trials resource center. So we'll have information about clinical trials, videos, everything like that, everything you can go to get comfortable, to learn more about clinical trials, to get you comfortable. And then we'll have some links to some clinical trials that are ongoing for you to get there. All of that will be coming soon on blackdoctor.org. And we're just really excited about that, because we need more Black people involved in clinical trials. All right, final question, and we'll get you out of here. If somebody is diagnosed with diabetic retinopathy, what's the first thing they should do?
The first thing they should do is listen to their physician. They want to understand, once you go, because you have to be, I'm assuming they've already been diagnosed, so they've already had their exam, is to understand, what are the goals? What are my short-term goals? And what are my long-term goals? and stick to the plan. I think that's the most important thing. And once you understand that, and retrospectively, you compare your photographs from baseline to maybe 6 months or a year later, you'd be really surprised on how you do. And most people, I think that's where they understand, the medicine that I was taking made a difference, because we can show you the photographs and you can see the diabetes melting away,
Mhm.
hemorrhages going away, swelling going away. And unlike other parts of medicine where you take other drugs, you don't always see those drastic responses. You may feel better, but you don't always see how your internal body is doing. And that's the great thing about what we do. We can actually take it deep inside your eye, take a journey inside your eye, and look at all the damaged tissue, and then see how it can be repaired with therapy.
Well, that is fantastic. So this has been a fantastic program. We talked about diabetic retinopathy. We gave you a refresher on diabetic retinopathy. We talked about glaucoma, and those two things are really prevalent in our communities, and they're preventable, right? But we've got to put in the work. We've got to be our own best health advocate. We've got to eat better. We've got to exercise more. Those are the things that we can do outside of the doctor's office. But once we start having a specialist, get one, right? If you don't have one, get one, and make your appointments and keep your appointments, right? So I have to say both of those things, because letting it linger is only going to make it harder on you and harder on your specialist, right? And so get in there early, start getting those checks before you start having vision loss, especially if you're diabetic. Start getting those checks now and have ongoing, so that your doctor knows, hey, he's at every year, he or she's every year, and get moving. Really, you're in the driver's seat of your own health, right? Your doctor is there riding shotgun with you to help give you advice. They're the navigator. They're going to tell you to turn here, turn there. But you're driving the car. And so you need to be more in control of your health and your health outcomes. So
I
that's
like that.
it.
Every 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 bad man has a Robin. I love it.
Yes, you got to be that. Got to be that. So thank you, Dr. Coney. We're going to let you go. Everybody, please share this with your friends. We're going to replay this tomorrow morning. It's so important for diabetics and non-diabetics. Get your eyes checked. You only got one pair. Do your best to maintain your vision as long as you can. With that, good night, and we'll see you next time.
Bye, Alice.